All right, welcome once again. Now we're being recorded. The recording will be posted on the committee's webpage shortly after this meeting. So in order to get us started, I'm going to turn it over to David DiGiuseppe, who can call the meeting to order.
Thank you, Mary. Good afternoon, everybody. It is now 2:02 p.m., and I call this meeting of our March FTech committee to order. As with previous meetings, we're going to begin with a land acknowledgement. And normally we talk about the tribes associated with the land that we're standing on, but because so many of us work in Olympia in Seattle, I wanted to call attention to another tribe in the state of Washington that we aim to serve. So today I would like to acknowledge the Samish Indian Nation for their stewardship of traditional lands in Northwest Washington, ranging from the Cascades to the western shores of the San Juan Islands. I'm not an expert on the history and culture of the Samish Indian Nation. I thank our colleagues at HCA for helping pull this acknowledgement together, and I hope this acknowledgement, as brief as it is, honors the work and culture of the Samish Indian Nation. The Samish Indian Nation has been persistent in their efforts to hold the federal government accountable to its trust responsibility, federal law, and the Treaty of Point Elliott in 1855. To this day, the Samish Indian Nation continues to seek federal trust status for additional tribal lands. We'd like to honor their stewardship and cultural connection to this land since time immemorial. Quoting from the Samish Indian Nation's website, the Samish work with state and federal agencies on several grants to protect the environment and preserve natural and cultural resources, as well as creating a sound economic base for our tribe and each individual family. I'd like to give a warm welcome to everyone joining us today for the 14th FTech meeting. I'll start with an overview of the agenda. We have a full agenda today. We'll begin with roll call. I'd also like to use this opportunity to allow committee members to better get to know each other as we have in the past with an icebreaker. So you can start thinking about this one, which is in your free time, what have you been doing lately to relax or have fun? After roll call, we'll vote on approving the January meeting summary. Following that, we'll hear public comments. After public comments, I will give an update from the Universal Healthcare Commission meeting from February. Mary Franzen from the Healthcare Authority will then provide the 2025 work plan update. Following that, following Mary, Peter Hallam from Milliman will present the report and results of Milliman's benefit design cost analysis. FTech members will have time for Q&A and discussion. We will take a short break after the discussion, and our final topic will be the draft cost containment memo presented by Todd Bratton from HCA. Now, Mary, I'll turn it back to you for our roll call.
Thank you, David. So as I'll be calling names, and remember our icebreaker today is what you do in your free time, what you do to relax and have fun. So I'll start with David, and then I will call people alphabetical by first name. So David DiGiuseppe.
Yes, I'm here. Over January and February, I was doing some cross-country skiing after about a decade of not doing it, and that was my relaxation. As we come to spring, I haven't figured out what I'm going to do, so if I seem stressed out, it's because of that.
Thank you. Christine Eibner.
Hi, yeah, I'm here, and my relaxation is practicing piano. I'm working right now on a Brahms intermezzo. I'm not very good, but I like to just sit there and try to do it because it takes my mind off a lot of other things.
Thank you. Eddie.
Present. Now that it's spring, I've been playing some tennis and watching tennis on TV too to get inspired, to get in shape.
Thank you. Esther. Esther. Okay. Ian.
I am present. In my free time, I like to play golf as well as, similar to Eddie, watch golf on TV to get inspiration.
Kai. Kai reached out and let us know that he's going to join this meeting a little late today, but we are expecting him in a bit. Pam.
Hi, Mary and everyone. Like David, I've been cross-country skiing all winter, and we've had a lot of snow in Washington this winter, so it's been pretty fabulous. And like David, I'm gonna have to figure out what to do next, but I think I still have a few days left.
Thank you. Robert.
Hi, present. I was going to say but what I've been doing lately is pulling weeds in my garden and also my driveway, but that wasn't very romantic. So, like Christine, I'm also a pianist, and I definitely relax playing piano. I'm working on a Astor Piazzolla tango, which I hope to play with a cellist friend sometime. So, anyway, that's what I do.
Oh, thank you. And Roger.
Present. I'm historically a gym rat, so I try to stay up to speed with a little bit of weightlifting and a bit of bike riding. So that challenge has been sort of riding between the rain.
Thank you. Okay, and David, I'm going to turn it back over to you.
Okay, please join me in turning to the second tab in your materials. The recording of the last meeting is posted on our webpage. We will use the consensus process for a vote on the approval of the January meeting summary. Is there any discussion of the meeting summary or proposed changes from my fellow FTAC members? All right, then I propose that the minutes are accepted without change. Any discussion of my proposal? All in favor say aye.
Aye.
Hi.
Aye.
Any opposed? Right, approved by consensus. Next, we're going to move on to public comment. So I'd like to thank those of you who take the time to follow these proceedings and the proceedings of the commission. In particular, I'd like to thank those of you who spend time preparing and presenting public comments. Some of the comments we have heard recently have expressed a desire to hear discussion of your comments in these meetings. While that is challenging to do in this forum with the time that we have allotted, I want to assure you that we hear your comments. At the February commission meeting, which I attended, my report out to the commission reflected the themes that you expressed at our January FTAC meeting. And in turn, at today's meeting, you'll likewise hear me update my fellow FTAC committee members about the public comments that I heard during the February commission meeting. So moving on to today's public commentary, committee members can find written public comments under tab 3. Individuals may sign up to provide public comment before the meeting, and we will hear from those individuals now. When you are called upon, please state your name and affiliation, if any, before speaking. Members of the public who are not on this list may raise their hand and be called upon to speak. You will be moved into the panel when you are called upon, and this may take a few moments before we can hear you. We will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comment. So, Mary, would you please start with the names of individuals who have signed up to provide public comment?
Sure. Thank you, David. And we've had 3 people sign up to provide comment, and we will invite them in the order in which they signed up. The first person who signed up is Rachel Snell. And Rachel, I think you can unmute yourself.
Can everybody hear me?
Yes.
Okay, give me one moment. Let me just get my screen ready. I need to exit full screen. All right, okay. Sorry, okay. Hello, my name is Rachel Snell, and for too long, many Washingtonians, such as myself, who work in the service industry, have been unable to fighting a never-ending battle to receive affordable and effective health care. To get a chance at health care, Many of us have to be at a job for a maximum amount of hours to even get a chance at being able to sign up for health care benefits. And that's assuming that those health care benefits are even available at the time of reaching those maximum minimum hours. Even with my good insurance provider, I still have to pay a ton of money out of pocket for dental care. Some may argue that passing a universal health care bill would cost too much tax dollars to fund. However, the truth could not be farther from this. 10 researchers from the National Academy of Science, affiliated with the Yale University, conducted a study. They calculated that a single-payer universal healthcare system in America would have saved $458 billion in 2017, $438 billion in 2019. This study only scratches the surface about the truth that universal healthcare would in fact save us millions of dollars here in the state of Washington alone. After all, why should I have to decide on whether or not to pay for a healthcare bill, groceries, or the cost of rent? Are we not the wealthiest country on planet Earth? And with single-payer healthcare, dental, vision, and mental health care must also be included. That's well-being. With the increased cost of living, none of us should have to decide between rent and healthcare. My name is Rachel Snell once again, and thank you so much for your time.
Thank you, Rachel. The next person who had signed up is Catherine Lewandowski.
That's your first exposure to that. Maybe a
Hello,
little too much.
can you hear me okay? I apologize. I'm at a kind of a noisy place. Catherine Lewandowski. Oh, good. Catherine Lewandowski, retired RN and board vice chair of Whole Washington. In your packet, you are reminded this month of the Universal Healthcare's mandate from the legislature in 2021 to create immediate and impactful changes in the healthcare access and delivery system in Washington, and to prepare the state for the creation of a healthcare system that provides coverage and access for all Washington residents through a unified financing system once the necessary federal authority has become available. Obviously, in the process of obtaining such federal authority, many of Washington's residents will lose their savings, their homes, their productivity, and for many, their lives. We do not live in a perfect world, and we do not live in a perfect government. We do not have a perfect government. In this last election, the citizens of Washington state clearly said that we live in a liberal state. We care about what happens to our neighbors, our friends, and our families. At Whole Washington, we understand that obtaining permission and support from our federal government will be difficult, but the Washington Health Trust can be passed and the transition plan can be started. We can begin to realize savings for our government, our businesses, and our citizens. What is so ingenious about the Washington Health Trust is that it is not dependent on obtaining federal authority in advance to begin deconstructing our current unsustainable healthcare system. It allows for a reasonable transition plan to get the ball rolling and can make impactful changes that will help all of our states to survive our current crumbling for-profit financing system and bumbling federal administration. And I have more, but I just say we would love for you to please do a dynamic fiscal note, ask for a dynamic fiscal note, or do a comprehensive funding study on the current proposed funding mechanisms within the current Washington State Health Trust, Senate Bill 5233 and House Bill 1445. Thank you.
Thank you. The third person who has signed up to comment is Raleigh Watts.
Were you able to hear me, Mary?
Yes.
Great. Yes, good afternoon, and thank you all for your work and David for your introduction. I'm Raleigh Watts, and in my free time, I volunteer with Whole Washington and also Healthcare is a Human Right and a group there known as HUCS. True confessions. I wish I had gotten better grades when I studied health systems modeling in graduate school. But that said, in reviewing carefully the packet this month, our group reviewed the Milliman affordability analysis starting on page 36. And we have 3 questions which we are asking the presenters to address during the discussion today. First, the modeling analysis excludes administrative costs. We'd like to understand the rationale for this. Second, how might the modeling have been impacted if administrative costs had been considered? What would the impact have been? And third, at what point in the FTAX work will administrative costs be modeled? We ask this because it's not hard to find literature, report after report, that show that administration billing, insurance-related costs, and profits collectively vary between 5 and 30% of costs, depending on the system design. This is well introduced in the Commission's November 2022 baseline report and now needs further granularity. Thank you again for your work and considering these questions today.
Thank you. Those are the folks who had signed up ahead of time. I do see one hand up. Maureen, if someone could move Maureen. So, and Maureen, when you get the link to say accept as being panelist, please accept, and then you'll be able to unmute yourself.
Well, whoops. Thank you very much. And thank you to the panel. My name is Maureen Brinkland, and I'm a co-signer on a written public comment that appears in today's meeting materials as co-chair of the HUX Subcommittee of Healthcare as a Human Right, Washington. The written comment expresses our concern, which is also raised by Aaron Katz's letter in the meeting materials, that governance is being left to the very end of phase 3 and your milestone tracker is illustrated on page 31 of today's meeting materials. Our letter, expresses our concern, and now I'm speaking to ask the FTAC to be so good as to reply to this concern. And I know you talked about that at the beginning, David, but a direct response from FTAC or from the UHCC or both would be appreciated. An open discussion about this concern during a public meeting would also suffice to help us understand how the decision to leave governance, an essential building block of any system, to such a late stage in the design process. In the spirit of being helpful, which is how we've been attending these meetings these last many years, our letter offers to present to the FTAC and to the UHCC an overview of how the two existing bills, the Washington Health Security Trust and the Washington Health Trust, both establish a governance structure as the basic building block of a unified healthcare system. In his letter, Mr. Katz also points out how the systems in other countries all created governance structures first, before tackling benefits and reimbursement issues. Thank you again for your continued attention and efforts to make a better healthcare system in Washington State. A number of us who have been joining with you in your efforts look forward to learning about what this idea of our proposal to address governance first aligns with your needs and desires. Thank you.
Thank you. Okay, I don't see any other hands up. We'll give that just another second to see if anyone else wants to put their hand up. All right, I am not seeing anything. So I think that it concludes our public comment period, and it goes back to you now, David.
Okay, thank you, Mary, and thank you all for commenting. Fellow committee members, I'd like to ask you to turn to tab 4 in your packets. That's where I'm going to do my update from last month's Universal Healthcare Commission meeting. Before I jump into that, I just want to take a moment and say thank you to you, Pam, for leading the commission, the FTAC, for the last 2 years. For showing us how to do that expertly, and it's intimidating to follow in your footsteps, but I appreciate the model that you set for me. I also just want to thank you more generally. You've been an inspiration to me, and I think a lot of people, in terms of pursuing accessible, affordable healthcare in the state of Washington as a whole. And I thank you for that as well.
Well, David, it's funny. Ironically, I was sitting here feeling very grateful to you that you've taken on leadership of this committee. And so far, I think you're doing a bang-up job. I think you're going to be fantastic. And it's going to be fun for me to be here as a participant. But thank you for those kind words and for leading us.
All right. Thank you, Pam. Okay. Let me navigate myself to tab 4. All right. So I'm on, Mary, does it help if I call out the slide numbers that I'm on under tab 4? I think you're on mute.
Sorry about that. I said, just let Audrey know she can advance the slides. If you just say next slide, she'll take care of it.
That's great. Yeah, I didn't see you pull that up. Okay, so Audrey, next slide, please. Okay, so again, this is just my recounting to all of you as to what happened at the February commission meeting. So first notable moment is that Patty Kuderer, our new state insurance commissioner, was present at the meeting, and I believe she's going to attend these meetings regularly, along with Jane Beyer, who is on her staff at the OIC. She said a few words and talked about her interest in universal healthcare, not just being, her personal interest, but feeling like it's paramount for the state and ultimately inevitable. If you want to see her remarks, you can see the link there on this particular slide. So, Audrey, if we could go to the next slide, please. Like I mentioned earlier, there was a public comment session the same way that we have it here. One of the comments was about eligibility. So when we present our timeline, you'll see that we note eligibility having been something we've already completed the discussion on. One of the commenters felt that we are not yet complete. It was premature to call that complete, and brought up an example of veterans who may not engage in the VA system. And so there was a little bit of discussion later in the meeting about folks who are either uninsured or underinsured and where they fit in the work that we've been doing. Hold on just a moment, my computer took over the screen. Okay, I'm back. So I think that's just something we can all think about as we reflect on the Milliman study and follow-on steps from that. There was, similar to what we heard today, there was the comment about governance and whether or not that can be accelerated in the timeline. And the commenter brought up the concept of rural electric cooperatives as a potential model for governance. And then finally, a commenter suggested that there be more explicit progress tracking, where we talk about where we are in the project plan and talk about anticipated milestones and whether or not we've hit those milestones. Next slide, please. There was a presentation on reference-based pricing. So if you remember, at our January meeting, we talked about the bill that was before the legislature, and we had suggestions. Among the conversation that we had, there was a suggestion that the commission take a more formal stance on the bill in terms of an endorsement. And that, in fact, happened, and the commission voted to go ahead and support the bill. Just of note, one of the commission members is a representative and felt that it was inappropriate to take a stand, so he abstained. Next slide, please. Margaret Smith Issa, who I think she presented to us as well, she presented to the commission and talked about the enactment of a similar bill in Oregon, the savings that it had generated, how it was based on Medicare rates. You can see her presentation linked here. Subsequent to that meeting, I was part of a Washington Health Alliance. I am part of a Washington Health Alliance committee, and there was a commentary written by Will Fox, who's an actuary at the Seattle office, Milliman Seattle office here. And he put out this paper where he had some commentary on the appropriateness of using Medicare as a reference point. And so I asked Mary and folks if they could link that here, because you all may be interested in seeing what Will's comments are on that. Next slide, please. This was a pretty engaging portion of the discussion in the last portion of the discussion, where representatives who are involved in either running or supporting rural hospitals attended as a panel. And Liz from HMA did a great job of walking through a series of questions to talk with the panelists about their experience. If you watch any session, I recommend taking a look at this session here, where you can see the link there. Can you go to the next slide, Audrey? I think we have some highlights from that on the next slide. Yeah, so a couple points here. You can see and read the numbers on the first one. I won't speak to that, but one of the thoughts that I found interesting was the interdependence across rural hospital catchment areas, where one hospital area might have some post-delivery service, post-acute services that another rural area doesn't have, and they share patients across their rural settings to take advantage of the post-acute services that they may not have in their own area. And then you can see the representatives of the hospitals talked about these various pressures they have on the cost side. And on the labor side, they talked about how they have to attract labor that has to drive long distances. And so it's quite expensive to pay wages that are competitive enough to get people to travel as far as they have to travel. They talked about the natural problem of inconsistent volume in an area with a small population. They talked about the criticality of transportation services, where their delivery systems actually help people get to and from appointments. The aging of their facilities is an issue. Trying to implement an EHR in a smaller organization is cost prohibitive. And then, they just feel that as a small fish in a big pond, they don't have much leverage in contract discussions with health plans. So it was an informative session. I think the commissioners really appreciated the panelists' contributions. I think that rounds out my slides. Is that right, Audrey? Can you please go to the next one? Oh, then there was just talk of the commission's next steps. So they were going to draft a letter in support of the reference-based pricing bill. They're looking forward to talking further about cost containment issues based on the discussion we're going to have at the end of today's meeting. And then you can see when their next meeting is here. Okay, Mayor, I think I'm done with that piece, and I kick it back to you for tab 5.
Thank you. Audrey, can we go to the next slide? This is going to be a really brief work plan update. We can go to the next slide. Again, I love having this slide here to revisit exactly what the legislature created this commission to do, the transitional solutions and the universal design. As you may recall, at a meeting, I'm going to get the date wrong, I think it was December, the commission decided that given everything going on in the legislature this year, that they would want to spend the first half of this year, first half of 2025, focusing more on universal design, and then they will pivot more toward transitional solutions in the second half of this calendar year. Next slide. Here is the milestone tracker. The green is the universal system design. You can see where we are trying to land in early 2026. I want to speak a bit about some of those bubbles on the universal system design. I don't think I have a slide about governance, but since we got a comment about it, I will pause and just speak to that. We are in the process of developing the April commission agenda. So it may be that if we will try to find out maybe if commission members want to revisit where governance is. We've heard quite a bit of comment about that. So just to acknowledge that we are hearing it and considering shifting the discussion. So the next slide. This talks about where we are with eligibility, and David clarified part of this earlier. I just wanted to add a little bit as well because we get questions about it. This is work done by FTAC to help the commission identify the population that has the greatest potential to be pooled in a universal system in the first iteration. That's what we are calling eligibility, and we are defining these people by where their coverage comes from now. So Medicaid, individual health plans, some employer-sponsored plans, PEB/CEB, uninsured and underinsured people. So that's the population we've been talking about. And the next slide. Going through the next additional topics and what's on today's agenda and what's coming up in the future. We have Milliman's cost modeling, and we see that as our springboard for the benefits and services discussion. You'll have further discussion on that in the May meeting. Todd will be leading us through the conversation about the cost containment principles and the memo to be discussed preliminary recommendations to go to the commission. And then in future agendas, we'll get more into provider participation and financing. So the next couple slides are just this really in the form of a picture rather than a form of a list, which sometimes is a little easier to follow. You can see where we are today, March, FTAC, benefits and services and cost containment, then sending things to April, Universal Healthcare Commission. The next slide just shows us where we'll be toward the end of 2025 with some extra spaces open at the end as topics come up and schedules shift a bit. So I can pause briefly if anyone has any questions before we move on. Pam.
Yeah, hi, Mary. So I wanted to just comment on governance because it has come up a few times, and I'm glad to hear that the commission's going to take it up as a conversation piece. It's hard for us at FTAC because that's kind of not what we do. We tend to be responsive to what the commission needs us to dig into further, and really thinking about our job title as technical and finance expertise. But I was on the commission that worked on health reform way back in the 90s, and we did start out appointing the governance process first. And I think it did bring a lot of clarity to the work that we did. And I didn't really think about it because, it was just the water we swam in. It was just how it was set up and designed. But I think it would be beneficial. I also think it might push the commission into looking at some of these questions where we have to kind of decide, where the fork in the road, which way are we going to go? Governance may help kind of develop some ways to ask those questions and to kind of get into some of the answers. So just being very encouraging in your comments of kind of bringing that forward with the commission now.
Thanks, Pam. I don't see other comments or questions. So David, I think it goes back to you.
Well, thanks for that insight and comment, Pam. And Mary, thanks for your overview. I think it's really helpful to ground all of us as to where we are, and I particularly like how you described it as phase one, where we're looking at what's most feasible, and it doesn't mean that that's the final product for the commission itself. So I'd ask everybody to turn to tab 6. This is where Peter from Milliman is going to present their team's work of the affordability analysis report, which was included with your meeting materials. I'll just remind you that Eddie, Roger, and I have served as the FTAC liaisons to work with Milliman. We've had a bit of a head start because of that in terms of seeing preliminary results and helping Milliman shape the study. And there's a lot of work that has gone into this. And Peter, we appreciate your and Ben's work on this and look forward to everyone else getting a chance to get into the details with you.
Yeah, and actually, I think the first slide on this is going to be mine. Yep, just keep going, Audrey, one forward. Okay, thank you. I just wanted to give a little bit of background and also say thank you to David and Eddie and Roger for acting as liaisons, providing guidance in this work. It was very helpful. And just a quick reminder of the purpose of the analysis. I'm going to keep it at a high level, and Peter's going to take us into the details on this one. We're modeling the cost impacts of providing selected benefit packages to a certain identified population. And we, again, as I said earlier, we see this as a starting point for the discussion of benefits and services that might be included in a universal design. I just want to pause and just point out what this is not, just to guard against misinterpretation. These are not firm proposals. This does not reflect any recommendation that has been endorsed by FTAC or been endorsed by the Commission. None of this has been endorsed yet. This is the starting point for figuring out what the recommendation should be. So I will pause and I will hand it over to Peter.
Thanks, Mary. Move on to the next slide, please. First, I'd like to say thanks to my colleagues here at Milliman. I'm a consulting actuary here who worked a great deal on this presentation, the results in it, as well as the associated reports. I'm also joined today by Ben Diedrich, who's a principal and consulting actuary here, Menko Yipma and Mark Franklin, who are associate actuaries here. All of whom did a great deal of work to develop these results. Thanks to them, thanks to FTech, and thanks to everyone here for the opportunity to present these. And I'll be happy to take some questions as we move through the presentation. I'd ask that most questions that come up are held to the end. I'll take a break after I first present results to collect a few questions, if there are any at that point. And Mary, I'll probably ask for your help managing that process. But for the most part, I'd ask we wait till the end so that we can get through the methodology and some of the further considerations in hopes that some of those sections might answer the questions for you. Aside from questions, what we intend to cover today is first some background. I'll read some disclaimers, relatively wordy sections of this, and then move directly into the results. I'll preface the results with the baseline included population or identified population, and that's the same population Mary discussed a few minutes ago. And I'll describe that in a bit more detail after we present the results. After providing a baseline of CY or calendar year 2023 starting point, I'll move on to the results of our several benefit scenarios that Mary talked about. We're not recommending these benefits or saying that these are the benefits in the future. We are saying we selected these benefits as example structures that folks are familiar with. After I present the results, again, I'll pause for a moment for questions and then move into a bit more detail about the cost sharing and the identified populations that underpin the results, provide the results of an alternative population, which is a slight augmentation of the same population that Mary talked about just a couple of moments ago. Talk in a bit more detail about the approach and methodology used, and then talk a bit about the sensitivity tests that underlie the ranges that are presented in the results. So also some additional sensitivity tests and some further considerations that were adjacent to our analysis but set aside. And really, Raleigh, I thank you for your questions that you provided ahead of time. I think that's when we'll probably touch on those. That said, I think I can move on to the next slide. So again, starting with a bit of a disclaimer and background. Next slide, please. I'll read this slide in entirety and for the remainder of the presentation, provide commentary and summary of what's being presented. This presentation, the report, and the report brief were drafted by Milliman on behalf of the Washington State Healthcare Authority and for the Finance Technical Advisory Committee. FTAC supports the Universal Healthcare Commission by providing technical guidance and options related to potential universal healthcare systems design. The results discussed in this presentation and the associated reports are not intended to determine or suggest any specific policy action or final program structure or design, and persons should consult qualified professionals before they take any specific actions. The report's authors are not advocating for the benefit structures, enrollment eligibility, provider reimbursement rates, or other elements of the underlying assumptions, and the authors have not examined the feasibility of the benefit designs. The report's authors do not intend to benefit or create a legal duty to any third-party recipient of this work. Modeled scenarios are intended to provide the spectrum of costs associated with the selected benefit and cost-sharing structures, i.e. the examples selected, but are not intended to represent a final benefit structure in the universal healthcare system. These results are not a projection of future cost of care. Next slide. Saying a bit more, we collected information from a variety of data sources, but we also have assumptions that underpin our analysis. Most of these larger assumptions were either derived from information provided by FTAC, the FTAC liaisons, HCA, or assumptions that we derived ourselves and then confirmed with HCA or FTAC liaisons throughout the process of our developing the results that we'll present today. Some examples of the assumptions are which populations would be included in our analysis, what the example benefit and cost sharing structures would be and how they would be applied to that included population. The assumed reimbursement rates that would be used for the purposes of our modeling, reasonable variation of our assumptions, and that was something that was developed more internally in order to account for variation in underlying data sources or assumptions. That administrative costs are being excluded from our analysis. Again, like I said a moment ago, what I'm presenting today does not represent any projection from calendar year 23, the baseline period, from which your data was collected into a future period, say 2025 or anytime in the future. If we were to project results, that would involve additional work and additional adjustment to our results, such as unit cost trends, utilization trends, expectations around population change, which were not included in our analysis. Next slide, please. So moving on to our modeling results. Again, I'll start briefly with baseline of what we saw in 2023, i.e. a summary of the included populations in 23, and then share the scenario-based results. Next slide, please. Again, this is a summary of calendar year 2023 data. So we have the several included populations or identified populations that Mary discussed previously, and I'll call out one in particular in just a moment. But we have Medicaid, PEB, and SEB populations, which are identified as current state program costs. So you can see approximately 2 million individuals in the Medicaid group, or 560,000 in the PEB and SEB groups, summing to 2.5 million roughly in the state program costs. And then other populations, which amount to about 840,000 individuals. And that, for the purposes of this identified population that will be discussed in this first round of results I'm sharing, is inclusive of essentially local government employees, individual health plans, and enrollees, and the uninsured, as well as religious organization health plan enrollees. Putting those together, we have our first identified population, which is about 3.4 million individuals. That's that first line with the red box around it. And $16.3 billion in total costs across these populations. These are historical costs, not related to the several benefit designs that we've applied. Moving on to the next slide. You see in that same red circled box, those same numbers as on the prior slide with a bit more detail added. Again, the 3.4 million individuals and the $16.3 billion in payer-paid amounts. We'll come back to that in just a moment, but to talk a bit more about what the scenarios are that we identified and modeled, I'll move to the first table on this slide where we have several different benefits scenarios that were selected. First, that's Medicaid-like benefit, or 100% or 100% actuarial value. In other words, a benefit where there is no cost sharing to the patients. The next scenario, which is a PEB UMP Classic-like benefit, where the actuarial value of that benefit is approximately 87% for the non-Medicaid eligible individuals. People who are identified as Medicaid eligible in our process always have a Medicaid benefit applied to them, or 100% actuarial value or no cost sharing. Folks who are identified as having or not being Medicaid eligible have the various scenario benefits. So that in this case would be the PEB UMP Classic-like benefit. And then finally, scenario 3, where we have a Cascade Silver or Silver Metal tier individual market-like plan benefit, and with an approximate actuarial value of 68%. With that preface of very high-level description of the benefits that were applied, I'll now move on to talking about the results. Starting with the baseline again, 3.4 million individuals, an allowed cost of $18 billion, patient-paid amount of $1.7 billion, and a payer-paid amount of $16.3 billion. When I refer to payer-paid, I mean the amount that the health plan would pay. While a patient may be responsible for cost sharing or even the whole cost of some services, that is what we're referring to as the patient-paid amount, and the payer-paid would be any amounts paid for by a health plan. In essence, for the purposes of what I'm presenting today, allowed cost is simply the addition or that sum of patient pay and payer paid. Moving on to the next slide. Now talking about moving between the baseline results and our scenario-based results. You can see we're still talking about that 3.4 million, that same population of 3.4 million people. Looking at the parenthetical in that population column, you might notice that the non-Medicaid portion of that population has decreased. That decrease represents a movement of some of the uninsured population from an uninsured status to a Medicaid status. In other words, we assume that a portion of the uninsured population is likely eligible for Medicaid and have moved them into the Medicaid program for the purposes of our analysis. We identified that population based on an estimate of individuals with incomes below the federal poverty level, or 138% of the federal poverty level. Looking across at the financial results, we see that looking at the allowed cost basis, we're moving from $18 billion in the baseline to a range of $20.2 billion to $23.7 billion in the scenario one results. That increase is a result of two primary forces. One is the addition of costs associated with uninsureds as they gain access to healthcare and are expected to increase their utilization rates. Another portion of costs that is related to that is individuals who are presently enrolled in health plans that have cost sharing, having their cost sharing removed and adjusting their utilization patterns because of that. Both of those forces serve to increase costs over the baseline the baseline summary to the expected range that I have here. Moving over to the payer paid amount, you'll note that this has also increased from $16.3 billion in the baseline to $20.2 billion to $23.7 billion in the in scenario one. That's both the forces that I just mentioned and also the shifting of costs from the patient liability to the payer paid amounts. So an additional force there that increases the payer paid amount even further over the baseline. Moving on to the next slide, please. Comparing scenario one to scenario two, we see a pattern of decreasing allowed costs, again, from that 20.2 to 23.7 range in scenario one to 18.3 to 21.4 billion in scenario two, and then further down in scenario three. This is a result of our estimation of the impacts of utilization and use patterns among the population as cost sharing increases. Moving off to the right, in addition to those utilization impacts that I just mentioned, we also have the impact of a portion of the liability moving from the payer paid amounts to the patient paid amounts. So there is an additional force at work on the payer paid side where costs are being shifted from a health plan to the patients themselves. You might notice that in the baseline, we have a payer paid of $16.3 billion. And then in the scenario three results, we have a estimated payer paid that brackets that amount at between 15.2 and 18.1 billion. You might also notice that the patient paid amount has increased relative to the baseline. The force at work there is generally, in addition to some other smaller ones, the movement of the uninsured population onto the health plan, which increases healthcare costs, and then an offsetting reduction to the health plan costs by shifting the cost to patients. Moving on to the next slide, I'll say that a bit more geometrically, and then I'll take a quick pause for some questions. I think this is a key element of our results. And so walking through from the left-hand side where we have the baseline population, plus that bracketed uninsured population at the top, we can think about this geometrically. We have the uninsured population, which has additional costs once they gain coverage. Because all we were modulating in our analysis was benefit costs. In order to offset those costs, that has to be moved into a reduction in benefit costs. So you can think about that again geometrically by looking at this center section. So the two boxes are on the same side, the orange box, as well as the gray and blue boxes. That offset of benefit reductions cannot be applied to the Medicaid eligible population because that population always has 100% actuarial value applied in their benefits. And so that benefit cost is all applied to individuals who are not eligible for Medicaid. I'll pause there to take some questions. I will admit, Mary, before I pass it off to you, that there are quite a few sections still to come in this presentation. And so there hopefully will be some answers that will come out as I go over those sections. So to you, Mary.
Yeah, thanks, Peter. We thought we'd pause just a few minutes to let the very beginning sink in till we get on to the rest. And Christine, your hand is up.
Yeah, just quickly, could you remind us what is in scope and what you're doing then with the cost of any benefits that are, or any health services that are out of scope? Are those in the numbers that you just showed, but just not paid for by the payer, or are they just set aside?
So I guess just to in terms of scope, maybe I need a little more detail about what you're talking about there. Sorry.
Like scope of services, are there any services that are like excluded from the scope of health spending? And then do they appear at all in these numbers, or are they just completely not considered?
Yeah, sure. Okay, so I think a couple of key elements that I glossed over so far. One, in the Medicaid population, in addition to excluding dual eligible enrollees entirely, which is more a population question, we've also excluded long-term support services. So that is one big block of services that has been excluded both in the scenarios and the baseline. We have also taken our baseline population and assumed that they would have some sort of dental coverage. I'll get into the details of what we assumed in a couple of minutes here. So that is an increase in costs in addition to the uninsured costs that I mentioned a couple of minutes ago. Those are the big changes. Otherwise, I would say these benefits were modeled as closely as we could to a PEB-like or PEB UMP Classic-like, a Cascade Silver-like, or a Medicaid-like for each of the three scenarios, barring those exclusions augments I just mentioned. I'd also say, I think in Appendix D of our full report, we have a pretty granular detail of exactly what benefits, how many Chiro visits and what cost sharing is expected to be there. So hopefully that'll provide the detail you're looking for.
Thank you.
Thank you. And Pam has a question.
Yeah, this is kind of a side question, but when I look at the uninsured, I was just, and you may have, if you went over the assumptions about them already, I apologize, but previously we used to think about the uninsured, they were shut out of the system because of pre-existing conditions or any number of reasons. Now, if they're Medicaid eligible, they can get Medicaid. So and if they want to get into the exchange, they can sign up on the exchange pretty much whenever they want to. With a few exceptions. But it sounds like your assumption is still that they would still have high healthcare needs, that they haven't found their way to the health system that actually is available to them.
Yeah, that's a good point. So we talk about that in the long form report. We've essentially assumed that when the uninsured gain access, they won't have any effects of pent up demand. So they won't suddenly have access to healthcare and use a bunch of services in year one, but that they would converge to the standard utilization rates that we see in the populations they're merging into. We did sensitivity test this as a bit of an aside. We've got some formal sensitivity tests in the long form report that I'll talk about later, but there are some additional sensitivity tests that are in the text where we say, well, what would happen if the uninsured population had utilization rates that were in fact 30% lower than the population that they merge into? And so you can see some of those effects there. Off the top of my head, I cannot remember the exact results of that sensitivity test. So I don't want to pretend to, but they are considered in the full form report. Does that make sense?
Yes.
Thank you, Pam. And I know, Peter, you have a whole lot more to get through, so we're going to take one more question before we go back, and it's Roger.
To Pam's question, Peter, you maybe can answer this one. When you've looked at the body of the uninsured population, you use, I think, some current population survey work to split those into the bucket of folks who are above 138%. And as you'll see later on, they go into a different benefit structure. And then those below 138% are treated in this like Medicaid fashion. And I think, Pam, to your point, in the report, you can see the percentage where they split between, again, above 138% and below in terms of numbers to kind of give you a little bit more feel for what those two groups might look like.
Yeah, thanks, Roger.
All right, Peter, you want to keep going?
Yep, sure thing. Next slide, please. So I'll say a bit more about the population. So maybe, Pam, this might be helpful. And then starting with a bit more information about the cost sharing scenarios that I gave a very brief introduction to a moment ago. So next slide, please. Saying a touch more about those cost sharing scenarios, we've got the three that I already discussed: Medicaid, PEB UMP Classic, and Cascade Silver-like benefit. Already discussed the actuarial values. little bit more information about the out-of-pocket maximum here, since that's a key element of benefit designs. Medicaid, of course, that's zero since there's no cost sharing. And PEB UMP Classic, that's $2,000 medical per year, and separately $2,000 for prescription drugs. And then in scenario 3, the Cascade Silver benefit, that would be $8,500 per year across all services. One other key assumption that we made was determining what level of medical management would be assumed for each of these scenarios. So in scenario 1, so Medicaid-like benefit, we assume that there would be limited medical management. In other words, there would be limited or no barriers to folks seeing specialists, no prior authorization required for prescription drugs, no management of individuals discharged, no or very limited management of individuals discharged from hospitals, or contact of folks with chronic conditions, for reminders to see regular healthcare or take required drugs to manage their conditions. Those sorts of activities we call medical management. In scenarios 2 and 3, we assume that there would be something like a status quo medical management. So kind of on average, what was observed in the baseline population. So that probably would include some level of prior authorization requirements, some level of step therapy or referral requirements on the medical side, as well as post-acute care follow-ups and chronic disease management activities. So that's a significant variation between our assumptions and these results beyond just the simple benefit designs that would be discussed in, like I said, I think Appendix D of our full report. This level of detail is, of course, also discussed in the full report. In terms of benefit details that are also changing across the scenarios, or excuse me, not described by the summary detail I just talked about in the several scenarios, the Medicaid benefits, as we talked about a moment ago, do not include long-term support services. So that is a large carve-out of services. PEB UMP Classic and the Cascade Silver benefits are broadly similar if you're familiar with one of those, albeit the cost sharing is very different between those two benefits. The Cascade Silver benefits in the individual market do have income-linked cost sharing reductions. So folks with income levels that might not make them eligible for the Medicaid program, but who are enrolled in the individual market might have lower cost sharing than the nominal cost sharing that you'd see in a Silver plan. We have not modeled those cost sharing reductions. In other words, taking an uninsured individual, for example, that we assume will be moved into, or that will have, that it has an income above 138% of that federal poverty level and will be subject to benefit, cost sharing differences across the scenarios. That individual would be subject to a plan that has 68% actuarial value in scenario 3 and not have a cost sharing reduction applied to them. Dental services were included in all scenarios. For the Medicaid eligible population, we have modeled a Medicaid-like benefit. For all populations in scenario 1, we have again modeled a Medicaid-like benefit. For the other two scenarios, scenario 2 and 3, for the non-Medicaid eligible population, we have modeled a PEB-like benefit. Some simplifications were made in our modeling of benefits. Some of those are discussed on like a line-by-line detail in that Appendix D, where we discuss each benefit in detail. But as an example, we would expect that the prescription drug formularies in force today for the baseline population would change between the baseline population and the several benefit scenarios that we looked at. For those not familiar, a prescription drug formulary is essentially a list of drugs and possibly some other administrative requirements that are covered by a health plan. So that would probably be different between the Medicaid populations, the PEB and SEB populations, as well as our other commercial group populations that were included in our analysis. We would also expect that those would be different under some other benefit design that were modeled in scenarios 1, 2, and 3. And that could have a substantial impact on drug utilization rates, patient cost for drugs, and plan costs for drugs. That is one example of the simplification of benefit designs that we had to make in the course of our modeling. Others, again, are detailed within the long form report. Next slide, please. Changing gears. This is a couple of charts of the included population. On the left-hand side, we have the whole state of Washington, with about half of it being excluded from our analysis. The included populations that we've already discussed are those colored slices, except the red slice. I'll come to that red slice that's pulled out even further in just a moment. So again, in that included population, that would be the Medicaid excluding duals, individual, local government and religious health plan enrolled, SAD, PEB, and the uninsured. Looking at the right-hand side, you can see how those populations make up the whole of the identified population. Once you include that red slice, you'll see right away that the uninsured is in fact the second largest group after the fully insured group in Medicaid. But second largest group in the results I've already shared at almost 10% when you include the fully insured group. That's a large portion of the population that we modeled. In a moment, I'll share results that also include this fully insured group. So that would be fully insured commercial group health plans that are not already included in, say, PEB, Kaiser enrolled individuals, local government enrolled individuals who have their health plans that are in a fully insured arrangement with insurer. Moving on to the next slide. Showing these populations in a slightly different manner here, I've broken them down in this table so that on the left-hand side, we see each of the populations just discussed. So that's PEB and SEB, local government and religious organization health plan enrolled, individual market, uninsured with income above 138% of FPL, stopping there for a moment. And then across from left to right, we have the various cost sharing scenarios that were applied to them. So Medicaid-like in scenario 1, PEB UMP Classic-like in scenario 2, and scenario 3 with Cascade Silver-like. Moving to that second section, we see uninsured individuals with income below 138% of the federal poverty level, as well as the currently Medicaid-enrolled individuals, excluding dual eligibles, have a Medicaid-like benefit in each of the three scenarios. So this is where it's important to draw out that the results that we're showing are in some sense a hybrid benefit design across multiple populations. So these populations, which are included in our results, always have a Medicaid benefit. And in contrast, the other populations that I just spoke about a moment ago have the varying benefits that are displayed here. That red section in the prior chart, which was excluded from the results I've shared already, are the other commercial group fully insured health plans. And so, again, they were excluded from the results I showed already as the identified population. In a moment, I'll show results for what I'm calling the alternative identified population, which also includes this selection of individuals. And this selection of individuals will be subject to the varying cost sharing structures. So in the next section, where I show results again, you'll see that they are results for them, which have them being modeled with a scenario 1 with a Medicaid-like benefit, scenario 2 with PEB UMP Classic, and scenario 3 with the Silver Plan-like benefit. There are also, of course, the several populations that were excluded, making up essentially the other half of Washington. So that would be self-insured group plans, federal employees, Veterans Administration covered, TRICARE covered, and Medicare enrolled individuals. Next slide, please. So again, I'm going to be sharing a second set of results. The distinction between this set of results and the prior one is that it includes other fully insured commercial group health plans. Next slide, please. So this is a larger population. At the top of this chart, you'll see the same familiar numbers from the prior results that I shared. So there's that 3.4 million individuals and the $16.3 billion that we talked about earlier on. At the bottom, in the red circled section, you see a larger population. That's about 4.1 million individuals and $20 billion in costs. That's the addition of the other fully insured commercial group health plan. So approximately 700,000 additional individuals gets you to that total. Next slide, please. So the same 4.1 million individuals, again, at the top, and then moving across from left to right, $22.6 billion in allowed costs, $2.6 billion in patient paid, and $20 billion in plan paid or payer paid, as I showed on the prior slide. Moving down this chart, we see larger numbers because this is a larger group of people. So you see that 4.1 million moving all the way down the chart. we can see that same effect of the assumption that some of the currently uninsured individuals would in fact be eligible for Medicaid, so that non-Medicaid population decreases from 2.1 million individuals in the baseline to about 2 million individuals in each of the three scenarios. That's the same decrement that we saw in the prior results, since the underlying uninsured population has not changed. The allowed cost increases and then decreases across the scenarios in exactly the same pattern as we saw before. So an increase associated with additional folks that are gaining insurance and lower cost sharing across most of the population. And on the right-hand side in scenario one, again, that same effect that I just said, in addition to the shift of patient obligations to the payer. Moving down to the lower right, we can take a look at that scenario 3, the Cascade Select benefit scenario, and that's the range of 18.7 billion to 22.3 billion, which again brackets the starting point or the baseline of $20 billion. Same effects at work here with increasing costs associated with lower plan payments, or excuse me, patient payments, and more access to coverage, and then decreasing allowed costs as patient payments increase, as well as decreasing payer costs because of those reasons, and obligations moving from the payer to patients. Next slide, please. So we've gotten through so far 2 sets of results, as well as some additional background around the cost sharing structures and identified populations that were included. I'm now going to step into some of the underlying methodology and our approach to developing results. After that, I'll talk about the sensitivity tests that drove the ranges that we displayed in our results, as well as some further considerations, and then I'll take some more questions at that time. So next slide, please. This is sort of an overarching view of our approach. We essentially had 3 modeling steps and 1 reporting step. We started with data and assumption collection. Where possible, we relied on information directly provided by FTAC, HCA, OIC, or other groups that we could get information from directly and understand that we are using that information correctly and how it was developed. Where that information was not available, we relied on public sources, and that could include sources from CMS, National Association of Insurance Commissioners, the American Community Survey, KFF, formerly known as Kaiser Family Foundation, as well as other public reporting sources. And then finally, where other sources were not available, we used proprietary data sets that we have. An example where that would have been used might have been where we could collect only high-level information about the total cost of care for large group population. We would then use our proprietary data to be able to estimate the proportion of total medical spend for commercial group populations that is attributable to, say, emergency department services or medical inpatient services. So that would be to add granularity and fidelity to our estimates. Once we had collected data, we also started developing related assumptions. That included the impacts of induced utilization. That would be the effect of folks' behavior in response to cost sharing changes. The estimates related to the medical management that I discussed a few minutes ago, as well as estimating a payment neutral reimbursement rate across all of the included populations. And I'll provide a bit more detail about that in just a couple of slides. We took all of that data and those assumptions, and where there was overlap, attempted to reconcile the data sources to, again, take another step to make sure that we are using the data sources correctly and that we don't have internal inconsistencies within the data sources on which we're relying. That reconciliation was often successful and is discussed in our report in a fair amount of detail. There were some cases where we were unable to reconcile sources. Where that occurred, we noted it. We relied on the information that we thought was most reliable. So, for example, we found one estimate of total Medicaid spend available from KFF and had other information provided by HCA. In that case, we relied on the information from HCA and not the information that was reported by KFF. Once we have reconciled data sources and assumptions, we fed that into our models where we applied the varying benefit scenarios and adjusted the underlying assumptions to come up with the sensitivity testing and the ranges that we displayed in our results. Those by population results were then consolidated into the single line total population results that were presented in this deck. The reporting that I've shared today is, I'd say, paralleled by the reporting in the short form report. So a lot of the same information I'm discussing today and the information included in this deck is included in that short form or brief report. It doesn't go into much more detail than what I'm discussing today. I will say that. There's also a long form report, and I would encourage folks to consider the information I'm providing, this deck, and the brief report as incomplete. The long form report discusses the considerations around the data sources we relied on, the methodology we used, and it's designed so that someone else can come along and hopefully recreate our results and understand the assumptions that we made in the course of developing them. I think with that, I can move on to the next slide. Saying a bit more about the development or the base development or collection of data sources. In short, what we were collecting there would be the enrollment estimates by each of the subpopulations we looked at. So uninsured, Medicaid, PEPSEB, et cetera. The cost of care for each of those subpopulations, as well as estimates of reimbursement rates across each of those populations so that we could come up with a single reimbursement rate for the total population that would be payment neutral to providers. Next slide, please. That payment calculation of payment neutral reimbursement rates. We first started with each of the estimates of each of the reimbursement rates across varying broad service categories by subpopulation. So Medicaid, inpatient medical, Medicaid, outpatient medical, et cetera. And then developed individual payment neutral reimbursement rates on a broad service category level. So down at the bottom, we have a composite reimbursement rate for inpatient medical, approximately 139% of Medicare was our estimate. We used, thank you, Mary. We used percent of Medicare as our baseline for comparison on the medical side and percent of average wholesale price on the prescription drug side here. I'll admit we didn't provide sufficient information for you to reproduce the calculation on this slide. This calculation was done on a by service category level, and the total expenditures I reported are only in aggregate, so you can't reproduce the numbers just by using this slide. The full report does include enough information for you to be able to do that. Appendix C contains that. Moving on to the next slide. So once we had those reimbursement levels and collected the base level data, we applied the various cost sharing scenarios benefits to the population. So again, Medicaid benefits are held constant for Medicaid enrolled. Other populations are being subject to the varying cost sharing scenarios. Dental's modeled across the board. And then we estimated the impacts, or excuse me, we also included the impacts of the varying assumptions underlying each of those scenarios. We compiled those results into the composite results that were presented today, and then essentially repeated the process, varying our underlying assumptions by small amounts to account for variability in underlying data sources or assumptions that we were less certain of, say, the medical spend for the uninsured population. Moving on to the next slide, please. So sensitivity tests and further considerations. This is the last section, just a single slide. This will discuss just briefly the source of the ranges that we provided today, as well as some further considerations that were excluded from our analysis. Next slide. Thank you. In terms of sensitivity tests, the chart on the right has 6 sensitivity tests. I'm going to focus on 1, 2, and 6 first. So that's varying provider reimbursement rates, varying prescription drug reimbursement rates, and other variation in utilization. The ranges presented in the results today represent us varying those and only those sensitivity tests by increasing the reimbursement rates, by increasing them by 5% and reducing them by 5% in sensitivity tests 1 and 2. And then finally, for sensitivity tests, increasing utilization rates by 3% and decreasing them by 3%. I want to emphasize that these don't represent the total range of possible outcomes of these scenarios. These are just some select sensitivity tests that were designed to account for variation in our underlying data sources where we had to make assumptions to say gap fill, or where we were uncertain of the reliability of some underlying data source that we had to pull from, say, NICS reports. So that's a very limited use case for these ranges. There are other things that could be easily imagined that would impact results that are way far outside of what we're estimating here. You could imagine the impacts of, say, a global pandemic causing healthcare costs to increase or decrease well outside of the ranges that we state here. I'll emphasize again that we're not providing a projection either, so that is somewhat outside of the scope at any rate. Sensitivity test 3 is actually something that we did include here. This was the alternative identified population. So this is the impact of increasing the identified population by the other fully insured commercial group population. So that sensitivity test was included, and then separately had sensitivity tests 1, 2, and 6 applied to it, resulting in the ranges that I displayed in that second section. Sensitivity tests 4 and 5 were held aside. They're not included in this presentation. They're not included in the brief report, but are included with detail in the full report, as well as the associated Appendix C. So that would be increasing and decreasing the Medicaid enrollment. One of particular importance, given our CY23 base period overlapped the disenrollment associated with the continuous enrollment provision of the COVID-19 pandemic. Another sensitivity test was our assumption of medical management. We varied that assumption by assuming lower medical management and seeing the impact of reduced medical management on the scenarios 2 and 3. Moving over to the further considerations. While the sensitivity tests are included in our analysis, the further considerations were excluded from our analysis. So this comes back to the administrative costs. Because we're early on in this process, we don't have information about what the administrative structure of this program would look like. We don't know if this would be a fee-for-service like program where the administrative costs could be on the lower end of the range that Raleigh cited earlier, or contracted with significant support by an ASO or administrative services organization or other entity in order to provide robust management services that could be considerably more expensive. So there's a broad range there. And because of that lack of knowledge of direction at this point, we excluded administrative costs from our estimates entirely. This is also, I should mention, why we had varying medical management assumptions as well, since we didn't know where the administrative services would be structured in order to support medical management practices. Practical reimbursement levels were not analyzed as part of this. While we did select a payment neutral reimbursement rate across populations, we didn't do any evaluation to check what the impacts to individual providers would be, or the appropriateness of the single % of Medicare rates that we used on the whole population level. We're not advocating for that system. We're not saying that it would be an equitable way to redistribute payments across providers. Health insurance market externalities were not considered, so that could be the response of other health insurers with a large portion of Washington State's population being covered by an alternative health plan. That could have impacts in terms of causing those remaining insurers and remaining insured populations having pressure on their benefit structures, provider reimbursement rates, or pressure related to their management of high risk or large claim costs. Population changes were not modeled. So while we did some sensitivity testing of the varying inclusion of fully insured commercial group and varying levels of Medicaid eligibles in our population, we did not make any assumptions, say, related to individuals from what are modeled as continuing self-insured commercial group plans, modulating their insurance or changing their coverage and resulting in more individuals flowing into this system or out of the system. So no population changes were modeled except for those couple of sensitivity tests already discussed. Pent-up demand, as already mentioned, was not modeled. So as uninsured individuals gain coverage, you might expect that in the initial phase of coverage, they might have some additional utilization. This was observed following the COVID-19 pandemic when elective healthcare was made available again. We saw increases in, for example, lab tests. That sort of pent-up demand was not modeled in our analysis. Program funding sources were not modeled. While we did take into account cases where program funding might have overlap and impacts within the provider reimbursement rates we modeled. For example, Medicaid pays for uncompensated care costs, and those uncompensated care costs could or could not be included in the payment for services made by the uninsured population. We made sure not to include those and double count those payments. But there are other sources of program funding beyond that, of course, that we did not include. So we did not include a consideration of federal funding, state funding sources, or other funding sources that are already funding care for the baseline population or couldn't fund care in the future. Finally, I'll mention as a broad-based limitation, while we examined the underlying data sources and did our best to model several benefit structures, there are simply some things that were outside of the information available to us or beyond the scope of the analysis we did. One of those examples mentioned before was, for example, detailed modeling of the prescription drug coverage in terms of formulary. Finally, I'll say that the further considerations that we have here are not intended to be a full list of further considerations, and the other considerations should come up during the course of further analyses by FTAC, UHCC, and discussion with stakeholders as well as other commission members. With that, I think I'm done, and I'll pass it back to you, Mary, for traffic control.
Thank you, and thank you very much, Peter. And I see 2 hands up already, so we'll start with David.
So, Peter, I think that was an exceptional walkthrough. I appreciate that. I just wanted, for all of my fellow committee members, wanted to tee up the Q&A just from my perspective. So I had a conversation with Vicki after the commission meeting, and I think what is going to be helpful to the commission is for me, not only to report out the results themselves, but what we as a committee think the commission should do with these results in terms of, would we advocate that the commission ask additional questions that would come back to us to answer, and we can help flesh out next steps with Milliman? Or does this analysis by itself support some decision making at the commission level? So I'm just hoping that as part of this discussion, number one, you feel like you can ask questions about the mechanics and secure your understanding of what Milliman did. And then number two, I'm hoping that by 3:45, we could come up with what I described in terms of next steps that we would recommend the commission take based on this, or next steps we'd like to do with this. So thank you for that.
Thanks so much, David. And Pam?
I'm not sure what to do about next steps, but I do have a simpler question, which is I wanted to echo what really impressive walkthrough. And it seemed like the sensitivity tests and further considerations was pretty exhaustive. How did you think about undocumented? Because that's a sizable chunk of our population and probably a sizable chunk of the uninsured.
Good question. In short, we didn't make any exception for them. So undocumented individuals that are currently in the uninsured population, which I assume is the group you're talking about, been migrated into either the Medicaid, and I guess I should say Medicaid-like payment structure, or into the non-Medicaid eligible population. So no exclusion for them. We took the entire uninsured population, which I can't remember the exact number off the top of my head, but around 400,000 people, if I remember right, and migrated them into the program either as Medicaid eligible or Medicaid not eligible.
Right. And I think that's actually an issue for the commission because it impacts federal funding.
Right.
Okay.
Do we have other questions and comments? Christine.
Yeah, I just wondered, did you incorporate anything like, I guess, what year is this for? And do we think of, like, I know there's a lot of concern about different types of drugs and, biologics that are coming on the market and might really increase costs in the next few years. Does this have anything, like any trend or any assumptions about that phenomenon?
In short, no. So we took CY23 data and applied these several benefit structures to them. So it's a snapshot in time. think the use case there would be taking a look at whether you're incrementing or decrementing costs rather than what the ultimate costs are under this program. I agree with you. There are significant upward pressures, particularly associated with drug costs. One other spot where we acknowledge that there's some significant variability would be payment rates under the Medicaid system, with some of the preprints that have come out recently in terms of increasing payment rates for some providers up to commercial.
Thank you. Roger.
Yes, thank you. So Peter, this is maybe a question for the presentation that goes forward to the commission. We have a baseline population we've taken us through, and then let's say the baseline plus the alternative population. And my thought is, and see this, you would concur with this. I think from the commission's perspective, they've said, kind of basically said there's two populations today that are going to be excluded for various reasons. One is Medicare, and then the family of ERISA related. And let's say veterans for a moment. When we look at kind of the sum total of after we exclude those, and when they're looking through these various charts and like, it seems to me, from one perspective, is this accurate that they really kind of ought to focus on the baseline plus the alternative, because that best captures, I think, from their perspective, what they think, who's in and out. Would you agree with that?
Based on, I want to be careful here, based on my understanding of the populations that are desired to be included or may be included, I would agree with that. That's my understanding of, and I think
sure.
You and the other FTech members would be much better suited to answering that than I. And hopefully we've given enough information to be clear about what you think is the most appropriate.
Kai.
Yes. Hey, Peter, I just echo my other committee members and thank you for this great presentation. I had a super high level question and comment just to peg my understanding of the numbers. I believe it's slide 12, at least in the deck that I have. Like for the, let's see, is it the PAB UMP Classic scenario 2, basically you have a payer increase cost of between 1 to 4 billion relative to baseline. And I want to understand like what that buys you. And so that's both a mixture of reduction in out-of-pocket costs on average, right, for the patient paid part, as well as increase in coverage for uninsured individuals, or coverage of uninsured individuals, of which there's two components, right? Like there's about 300,000 or so, I think, if I back calculate your numbers, for uninsured that would be covered, if I got that right. And part of which are below FPL and some are above, and so part are like Medicaid paid, and then another part is not. And so like I wonder if you have some measure that can peg like that increasing costs when you have cost neutrality, right? Like in terms of patient paid being 1.7 billion again. In today's system, if you were to try and get these same uninsured individuals covered, how much would it increase payer spending? Like just to peg like how in a fragmented system, getting those people covered, how much that would cost relative to this scenario to universal coverage system.
So just to make sure, I'm going to try and say it back to you, just to make sure I captured it right.
Yeah.
Where if you were to say, looking back at what we have, I think on actually, could you maybe move back to say slide, that's probably going to be a different number here. Our numbered slide 9 would maybe be a decent starting point. And actually, it could be after that. I apologize. Maybe better example would be slide 19. So down, I think it was further down. I'm sorry for making you do this. Looks like 55, maybe. Slide 55. There you go. Thank you. Yeah, perfect. Okay. So you're looking at, just to make sure we're talking about the same thing here, we'd be looking at the patient paid of 2.6 billion here versus in the PEB UMP classic scenario of the 1.6 to 1.8 billion, which represents somewhere on the order of a $0.9 billion decrease in patient paid.
Yeah. I was looking at the analogous one where you didn't include the other fully insured. This includes the fully insured, but I think the numbers are going to be about the same, right?
Right. Yeah. So you to say your question another way, you'd be wondering what the total plan paid would be if you increase the patient paid essentially by another 0.9 billion to get back to that 2.6 billion, where we would land on that range on the right hand side, the payer paid amount. Is that essentially what you're asking for?
As compared to a scenario today in which this is all under presumed universal coverage system, as compared to that scenario versus one in which today, with today's fragmented coverage system, you were to be able to cover all individuals, same set of 300,000 or so individuals, 9%, right, of the uninsured, who are currently uninsured, right, covering those individuals. How much would that increase payer paid, like under both systems? Like basically, how much more or less would it cost under a universal system?
Yeah, right. Okay. I think that so there are a couple of confounding things based on the information here. I don't know that we provide enough information in the exhibits that we have now in our full report to get exactly to what you're saying. But I think you could use the results that we have here to interpolate and come up with an approximation of that cost by interpolating between the allowed costs here by increasing the patient paid by, I guess 30% of the difference between scenarios 2 and 3. Then you'd also decrease the allowed costs commensurately and then calculate the payer paid as allowed minus the new patient pay amount. So that would, I think, give you what you're talking about. Does that sound right? It might not be the same thing. I hope we're talking apples to apples, but I'm not certain, frankly.
Yeah. Maybe I'll follow up offline maybe with the email. Yeah.
I'm happy to, and I think that's part of the intention, Mary, is that we'll continue to try and support that. Yeah, right, with question answering. Sorry if I'm not capturing the question right now.
Well, and Peter, that might be related to some of the conversations we've had at the liaison group. So I think, Kai, if you can write out your question, I think that would be help to clarify. And I think Peter's right that there's a way to answer that question. So I'm curious, folks, I'm thinking of being in front of the commission. I guess, Mary, I don't know, are we inviting Milliman to the commission to report out also, or am I the only voice of summarizing what we've learned from Milliman to the commission?
I don't think we've determined that yet. I don't know, David. We might send you out there to explain all of this. We're not sure.
Well, I'm game for it as long as I can add more disclaimer slides than Peter has. So what I'm thinking, though, is when I look at this slide or slide 11 in particular, one of the primary punchlines to me is the billion-dollar differences as we move across the rows. And it seems like, as I think about the comments you all have made or the questions you all have asked and how we would characterize the results to the commission, one would be, if you bring these populations together and you put them under a certain structure, $2 billion to move from baseline to scenario 1, $2 billion to move from 1 to 2, et cetera. I think we could also tee up that there are outstanding questions that the commission will have to wrestle with in terms of that ERISA fully insured population that Peter did the sensitivity test on, and the undocumented population related to Pam's question. I think this analysis also shows the difference, the total cost of the system, depending on whether there's zero cost sharing or some cost sharing. And I think that gives the commission something to chew on in terms of do they want to advocate for no cost sharing or some cost sharing, and that flows into the financing question. So I'm just saying that all out loud in case any of you have reactions to help shape what does that update to the commission look like.
Thank you, David. And Gary's hand is up.
Thanks, Mary. So, Peter, I want to put forth a possible takeaway that the commission could understand, from this data, and see if I'm understanding it correctly, and you tell me if I'm right or wrong. As I understand it, these medical costs and the range of increased costs depending on which benefit design you choose are agnostic as to what the structure of the universal healthcare system is. So in other words, I think you've noted that if you have more medical management, that might affect these numbers. If you have just fee for service, that might affect these numbers. And certainly you can assume higher or lower administrative costs compared to baseline, depending on the structure of the system. But none of that is part of this. This is just, these are the medical costs that that your modeling will exist regardless of what the structure of the system is. These medical costs are going to be there.
Yeah, I would say it a bit differently. So we had to make some assumption about what administrative services would be kind of overlaid on the system. So and the assumptions that we made, which we're calling medical management, are effectively status quo in scenarios 2 and 3. So that's, we essentially took our models and calibrated the medical management to what we observed in the base period. So that would assume that whatever administrative services are layered on the existing health plans. So again, that could be all sorts of different things that various health plans are doing, are going to be enforced in this new state. The one exception to that is that in the Medicaid-like benefit, we essentially said we're going to assume there's very limited administrative services like that, because in large part it would be very difficult to encourage someone to not go to a specialist if you're not going to have any financial consequence to going to a specialist, for example. So that's where we had what we would call like a fee-for-service like medical management assumption. So we essentially brought down that assumption. We did, as I think sensitivity test 5 numbered in the report, I'm remembering the number correctly, we did actually take scenarios 2 and 3 and say, well, what happens if you have this cost sharing structure, but you actually just have a fee for service like management? So there's no really administrative support service for patients, on top of just getting claims paid. So we did provide a couple of examples there. I would say that was about as close as we could come to agnostic of, because the baseline data has some management, we had to have some sort of assumption related to management in the future. So that's how we developed it. Does that answer your question?
Yes, yeah, that makes sense. Thank you.
And Roger, did you have a question or a comment?
Well, I do. This is, I think, following up to David, the question you had posed, and let me see if I understand part of that. And that would be, this information is going to be presented to the Universal Healthcare, to the commission. And are you suggesting, or maybe I'd like to suggest, that with that might be several questions, let's say follow-up questions we might have to the commission as to conceivably next steps in what is essentially building the benefit design, cost sharing, if you will, some of the deliverables that they want to achieve by the end of this coming calendar year. So are you opening up part of our discussion to what some of those questions back to the commission might be? Or
yes. Yeah. And, given that we have 4 minutes, Mary, I don't know how you feel about this, but I'm wondering if I could invite folks to send me those questions, because, Roger, what I'm imagining is sharing the punchlines of the analysis, the results of the analysis with the commission. And I think the question we have to be prepared to answer is, so what? So, okay, great, we have these results. Now what? And I think you've described well what I was thinking, that we want to lay out a potential pathway of here are the questions that could be answered next with additional iterations of this analysis, or even with this analysis.
Okay, so what you're suggesting, one more time, David, is rather than engaged right now, that we put together our respective questions and give those back to you and Mary for consideration. Is that what you're suggesting?
Yeah, if that doesn't trouble you, Mary, I think that's probably what we need to do given the time that we have. Yeah.
Okay.
Yeah, I mean, it takes a while to digest all of this, we realize. And okay, we're Eddie. It's better to hear from you than from me. Eddie.
Got it. So I just wanted to quick chime in because what the study is and what it's not. This is a very comprehensive piece of work, and for CY23, what's in the base is what was there for cost containment. All that went along with that is there implied. So, keeping everything cost neutral across all plans. Now, if we take these numbers and then want to apply some type of, cost, bending tool, it's going to be kind of interesting to how we use that. I don't know, Peter, if you have any thoughts on that. If you don't hold the cost constant, and then you want to say, okay, well, we're going to institute some type of cost sharing, but there is an implied amount of cost sharing in the base already in CY23 data.
I think you kind of broke up at the end, but to state your question, I think you're saying, we essentially had a status quo that's baked into our results in some ways, and what the savings could be built on top of that. And I see, obviously the lever we investigated was the benefit structure. I think there are other levers that could involve selections of different populations, which I don't know if that's something that you guys are looking at, and I'm not encouraging that necessarily, just mentioning the other things. Another would be, yes, administrative structures, potentially. This baseline has some administrative management of, say, the PEP-SEB population in terms of how their benefit is managed, already built in. So that seems like you're essentially saying that if you want to have further cost savings, you would have a more aggressive, administrative supportive structure, which could be more stringent restrictions on care availability to the members. Increased cost sharing, which is when we modeled, and then finally, provider reimbursement rates that could be modulated away from the cost neutral basis that we modeled to something that is different. And now, again, we did some simplification, and for modeling purposes of provider reimbursement rate that was payment neutral across all of the populations. You could select subsets of services or think about how the market would be impacted by adjustments to provider reimbursement rates. But that gets pretty granular pretty quickly, because a blanket reduction or something like that probably is not something that will give you really reasonable or useful results, I would guess, given you'd have to focus that on specific areas.
So kind of as we move forward with these numbers, the different ways we can work with healthcare management, if we wanted to try to understand how much is in the base versus what we could do or what others could do with this to not hold the cost constant, to bring down the costs. If we were going to look at changing anything, I guess that's probably a longer question I have to develop. So
I think I would say I'm happy to take a longer question. I know we're running short on time, but I would say one starting point would be to look at the sensitivity tests, look at the sort of output you get for each input that we provide. So if you modulate reimbursement rates up by 1% or down by 1%, kind of talking against what I just said, but you could get a rough idea of, all right, well, we get 4 cents, or excuse me, 95 cents on the dollar, or 90 cents on the dollar for an adjustment in reimbursement rates because of how things shift across patient pay and payer pay and things like that. So you might be able to get some ideas of where you have the biggest levers to pull and the smaller levers. And so you can at least focus where your attention should be in order to modulate costs. One of those examples would be, if you had a medical management system that is somewhere between fee-for-service system and the status quo, you can kind of get an idea of how much of a difference that is and think about, well, if we could do a bit better than the status quo, what kind of savings could we expect there? So I would take a look at those sensitivity tests and see if they give you some idea of where to go next. And again, we're happy to continue this conversation.
And Peter, maybe you can hang on for our cost containment memo discussion, because we'll be talking about what we want to recommend in terms of cost containment strategies. And if we have time, you might be able to comment on which of those are baked in versus not baked in, either today or at a follow-up conversation. So Mary, maybe we should give Pam the last word on this one.
Yeah, that's what I'm thinking.
Okay, I'll be speedy. The only thing I was going to say is that I wish we had more time for this conversation, of course. And I think, Mary, I was going to ask if you could share people's questions with each other so that we can see even like a go round before we submit, so that we can be kind of inspired by hearing what other people say or even chime in.
Thank you. I think it's a blank piece of paper is a hard place to start. So we will share that and share some of the, initial ideas just came out of Eddie and Peter talking, and, point people where to look if that's helpful, just to get the conversation started.
Yeah, part of it is, I think most of us would be fine with blank paper. I just think it's an opportunity to hear from each other, which we're not going to get to do by doing it this way. So
Sure.
that's
yeah, and I like that, Pam. I'm even thinking if we could circulate a draft of what's going to go to the commission as the outcome of our discussion here, so everybody can see, all of us can see that and weigh in and make sure that we have some consensus on that.
Yeah. Okay. Thanks.
Okay. Thank you all very much. And
Okay,
David,
so
I think it's
is
you
this
again.
is this where we're taking a 5-minute break, I believe? I'm wondering, is everyone okay if we come back at 3:55 just to make it a nice round number? Okay.
Sounds good.
See you in 6 minutes.
Thanks, everybody.
Are you uncrashed?
Yes, I made it back in the nick of time. Here I am.
Good. All right, it's 3:55.
Nice job, folks.
Yeah, thanks to everybody. It's a lot of material to get through in a short time. All right, welcome back, everybody. I want to direct you to tab 7 in your packets. And Todd Bratton from the Healthcare Authority is going to present the current draft of our cost containment memo. Welcome, Todd.
Thank you, David. Next slide, please, Audrey. So the Healthcare Authority staff here would like to thank FTAC members for helping draft this cost containment memo, the principles and the strategies framework. The principles and the framework are the two main components of this draft memo, which in final form will provide a starting point for FTAC and the Commission to develop recommendations on cost containment now and through transition to a unified healthcare system. So we have these three goals today to help move this memo closer to completion. The first two goals are fairly straightforward, but we're going to spend about 10 minutes maximum on each of these to make sure we reach consensus on the next steps for each of these goals. The third goal is a little more fun and ambiguous, so we'll get to that one after we get through the first two. And Mary Franzen will be helping capture any edits or guidance as we move through this exercise. So if we could go to the next slide, please. Our first goal is to discuss, amend, adopt the principles that are included in this cost containment memo. So Mary, can you please share the memo with the principles?
Okay, let's see if I can do this. Okay, did that work?
That worked. That's great.
All right. Let's hope my Zoom doesn't crash again.
Thanks, Mary. So my first question for FTAC members is really to get a sense of whether any edits you would like to make now we could do in the next few minutes, or if there are more significant edits that FTAC members would like to maybe make between meetings. So I guess that's my first question. Do we feel like there are significant edits that we should continue to gain input from FTAC members on? Or are we, is FTAC in a position that they are ready to accept these or make minor edits at this time? So I guess if there's anyone who has major edits, that's who I would be curious if we have major edits at this time. Bob.
Yeah, I don't have major edits. I just had a few edits to a couple of the sections and wording. But rather than spend time now going through those, maybe I could just give you a kind of a marked up copy and then you can do what you want with it between meetings, if that works. I mean, there's just a few minor things, like a few words missing in a couple of sections. And anyway, if that's okay, I'll just send my comments in after the meeting. Otherwise, I thought you did a great job. Yeah. I didn't have any major issues with things.
Thank you, Bob. If you don't mind, I think if they're minor, we could probably make those revisions now. Mary has it pulled up and can make any revisions if it will just take a few minutes here.
Okay. Well, so we're on the principles now, right? Sorry, I'm going through. They're also looking at your section about coding. Okay, so principle 2, adopt transitional cost containment affordability strategies while state policymakers consider options for a universal healthcare system. I think you just left out a word there. Principle 3, adopt evidence-based strategies. Should you add cost containment to that? Evidence-based cost containment strategies. I wasn't sure what strategies you were referring to in principle 3. So that was just a thought. And then principle 5, I just was wondering, you've got here, identify and focus on primary drivers, healthcare spending and spending growth, including actions to provide a price. I'm sorry, principle 4, address healthcare costs with respect to, I didn't know what with respect to it meant exactly. Taking into consideration patient access, quality of care. Anyway, it was just maybe a little vague, but those are the kind of the minor wordsmithing comments that I had, not significant. So do what you want with those.
Thank you, Bob. And these were going to go before the commission after FTAC has consensus on them. So they may provide further feedback, but we appreciate any feedback you offer right now. Pam?
Yeah, if we were doing minor ones, the use of equity at the last one is a little confusing what we're talking about. We're talking about equity in terms of equity of healthcare, equity of payments.
We could also split that into a separate, addressing payment equity and addressing healthcare disparities, if that would make more sense.
The payment equity one threw me off. So I just to be clear about the use of the term equity, what you're meaning. That's all.
Thank you. Any other suggestions? Mary's working on wordsmithing that. Are there any other minor suggestions at this time? Roger. Oh, we got you on mute, Roger.
This is more just a comment, and I think it's on principle 7. And again, the notion of the work that the commission does and FTAC, et cetera, its coordination with the Healthcare Cost Transparency Board. I guess I think that's essential at this juncture, given we said many times before, that is the major, if you will, emphasis that the legislature is placing for the state's, if you will, cost containment efforts. So the fact that we'll be coordinating with them is a logical one, and I appreciate it being part of these principles.
Thank you, Roger. I agree. David.
So, Todd, this might be more of a protocol question. I think the principles capture the concepts that are important, and I agree with everyone that has spoken so far. It feels to me like there's redundancy across the principles, and to make it more impactful and digestible to the commission, we could potentially streamline it. I don't want that to stand in the way of quickly approving it. And so the protocol question is, I think from our previous discussion, we're probably going to have another round of communication with each other via email before things go to the commission, as we're talking about how to present and what to do with the Millman results. Would it make sense to collect comments today and potentially circulate another draft, or would you prefer to, well, there's a question for everybody, would you prefer to just adopt it today and move on, which would be fine with me if that's what the group wants to do.
Thanks, David. I think a good plan could be for us to circulate a draft based on these comments here today, with the plan of at least sharing that next draft with the commission at their next meeting, to say these are the principles that FTAC has drafted so far, and gained feedback from the commission at that time. Does that sound?
Is there a difference between sharing a draft and sharing adopted principles? Because if our goal is to adopt some principles and move on and share that with the commission, I would I would lean toward, let's just do that and have it be done, versus if for some reason the draft would cause us, to just prolong it, I guess.
I think the commission may have feedback either way, whether FTAC adopts these as is now or does continued revisions. So we're happy to make some modifications and send out that prior to sharing with the commission.
And Kai's hand is up. I don't know if you can see that,
Kai?
Todd.
Great. Yeah, thanks. I have a question for my committee members around like maybe a bigger picture item. Is like, do we need a principle around measurement, right? Like if you see like the notions behind the number of these principles it's around implementation, right? Adopt, trust, and then the limitations around how you adopt. But I wonder like if you need one around like the measurement of the evidence-based strategies and the outcomes associated with them, like the cost and quality associated with them. I mean, like, although they're evidence-based, like the really devil's in details in terms of how you implement and whether or not it on average drives, the outcomes that we're seeking. And then also like whether it induces some, inequities, right? So like some principle around measurement. I don't know if like folks feel that a principle around that would be necessary.
Kai, would you be willing to draft a principle along those lines and send that to us for inclusion in the next draft?
Sure.
Thank you so much. We'll send out a reminder about this draft as well and the next steps. So yeah, the principles will really they may not capture everything, but they're a starting point for the commission to say any cost containment strategy that the legislature adopts may want to have reference to these principles. Roger.
Yeah, this is one that's hopefully you folks can share with the commission. I think it's good, we say, here's some principles and here are some ideas and, what do you think about them, commission? My cautionary note is if they want us to send those back to us and say, okay, give us guidance on one or two of these things. To give them summative guidance is going to require, in my humble opinion, a fair degree of analysis. And I'm very concerned about our resource band to be able to do that to the level that the commission may want to be looking for. And to me, an example is we were doing some great work with Milliman, on a benefit design. We have more work to do on that. This is a chunk of consulting services, resources, et cetera, to accomplish that. And what I'm nervous about is if this list of ideas that we share with them, they say, well, they all sound good, go do something with them. I'm being a little bit facetious here. Is an acknowledgement to them is in order to do that, we all are going to need more resources and time to do justice to figure that out, other than just having a chat among ourselves about this. Am I making sense what I'm trying to say?
Makes sense to me, Roger. I think that the recommendations from the commission can consider these principles and maybe not go too far beyond the principles and what they recommend to the legislature. There might be some specific strategies that FTAC recommends that we can do more analysis around that help meet some of these principles. So this would be the starting point. Yep.
Actually, and I'm less concerned about the principles. I'm just saying if we get into, you have a nice list of strategies, right? And any one of those deserve a lot of merit. And, to do justice and giving the feedback back to the commission is going to take a lot of work, and my own opinion, some consulting support for us to be able to do justice, to give them the guidance that they may be asking for. It's clearly what they need. So, enough said.
Yeah, this is Eddie. Am I on? Yeah.
Yep. Thank you, Eddie.
So yeah, I was kind of like reading through it, and then I read through it again, and then kind of what Roger had said and David. I think there's strategies, principles, and values, and they're kind of getting mushed together in my mind. So yeah, I was thinking that what was in here was more than just what I think as of principles. So a shorter list of principles probably would help.
Okay, sounds good. Yeah, this has gone through several iterations, and we do appreciate all the feedback from FTAC members that we have gotten along the way. This is currently where it stands. So I think what we'll do at this point is ask for more feedback on these before we get it to the commission, and we'll do that via email. So we can continue to work on these in between meetings with HCA staff and the FTAC members. At this time, I think I will move on to the framework if we have consensus that we should do a little more work on these principles. And maybe we can do some condensing and a little bit more streamlining of the principles, and then send out future drafts, and would appreciate any feedback on those as soon as possible. But we'll get out an email on that. Mary, if you could stop sharing, we'll go back to the slide deck just for a second. And then our goal 2, if Audrey can pull up our goal 2. Our goal 2 is to come up to decide whether this framework works for categorizing all these various strategies that we've sort of looked at the world of healthcare systems and what do they do to contain costs. So we just kind of pulled in this large menu of different things, and then with FTAC member feedback, we've organized them into 4 categories. So I don't see the slides up at this time, but Mary, I guess you could share the memo again, and the 3rd page, I believe, starts the framework.
Okay, you want me up here? There.
Yep, I guess this one works.
Okay.
So yeah, just wanted to get FTAC member sense on whether these 4 categories work to be the starting point for where we group all of these various strategies. And so the purpose of this is just to have a shared understanding between FTAC members and the commission about how these strategies might be organized. And then, so hopefully this discussion will lead to FTAC members being able to make recommendations within this framework. So I'll open it up to see whether FTAC members have any thoughts on this framework. Roger? You're on mute, Roger.
Thank you for including category 4, which was, I think, a newer one off of than the original draft. I'll leave aside the title for a moment, but there's a group of interventions that, if somebody's administering this program, can take to deal with the fact of lack of better words, cost overruns. In other words, our expenditures exceeding what our revenues coming into it. There's a variety of if you will, adjustments, changes in utilization management, for example, even pricing structures that can be introduced in theory to reduce trend or bring it within the parameters of the revenue sources. There's also a group of ones that are, in my mind, more fundamental, and I think you've grouped them in that area. And the ones, just to kind of go through those, because we've done this before at times, but if a program is facing, even with universal coverage, we don't have enough money, you can freeze enrollment, for example. I mean, we've done that in a variety of state administered programs in the past. We can change the benefit design or the cost sharing. There's several of those that, in my mind, you can do, but they kind of represent a more fundamental change or structure to the program than would be the ongoing management. Hopefully I make that distinction. So I'm just saying to me, that's to a degree what category 4 represents. The title may not be the appropriate one, but I'm glad that we've taken some of those and put them in that latter bucket, because they do represent a significant change to what would be otherwise the program design.
Thanks for that explanation. I like the categories in 1, 2, and 3 line up with how I think about total cost of care, and I wasn't sure what category 4 meant, and you gave it adequate description. So I like what we have on this page.
Are there any other comments or concerns about how we've generally structured this framework? Okay, that's great to hear. So we can move on to the next homework that we asked you all about. And feel free to make any more comments in the future drafts about this if you do have concerns about the framework or how it's titled and organized here. But I think it's a way for us to at least start listing some of the various strategies in various categories. Mary, if we could go down to the next page, I believe.
Here?
Yep.
Okay.
Thank you. So we asked FTAC members to code prior to this meeting, and we really understand if you did not have time in the last week to get to that. So we did not expect to spend a lot of time here in this meeting doing this exercise, but essentially wanted to gain consensus from you all that this is a good starting point for identifying which strategies should be included in any unified healthcare system, and also what strategies might be transitional only, and what strategies we want to keep in the toolbox that may not necessarily be included as permanent fixtures of a unified design, but would be available in the toolbox to use and be flexible with as time goes on. So those are the general coding categories that we've included here. And so this really gets to the meat and potatoes of how we hope that FTAC can make recommendations to the commission on specific strategies. And so at this time, I would be curious if there are certain transitional strategies that FTAC has already researched, has already been learning about, that any modifications, not necessarily new strategies, but modifications to what the state is currently doing, or any other suggestions that really stood out that from this list of menu that FTAC would like to sort of prioritize in this discussion. Roger?
Yeah, thanks again. Yeah, Todd. So this is a definitional question. When we read the underlying statute, it says go out and design a new system, unified financing system, and bring forth the legislature, and they'll take said action. It also directs the commission to work on what they've kind of phrased as transitional strategies, and when you read the underlying legislation, it's come back with things you can do now. We don't need health reform to do a variety of these things, and we're looking forward to the commission's ideas and how to address those now, and they also complement what might be in the new health reform system. So when I see the use of transitional, that's what that means to me. I just want to be sure about that. In other words, if I said, well, let me just try one here, just a minute. One that's in code B, I would say, well, this is something good to do in the new design of the system, and just want to be sure I'm saying this right, and this is something we ought to be engaged in now. A good example, Bob's here, global budgeting, right? We've had good conversations about it. As Bob was, it's no small issue to get there. So the question would be, is that something we would want to say, start doing that now, and yes, adopt it then or not? So I guess I'm trying to use this to clarify what, in your mind, these codes mean. So I may muddle the water in what I'm trying to say here, but could you feedback to me what I think I'm saying?
No, I've got you, Roger. I think what you're saying is that how do from the codes we make recommendations? And so our idea about coding them was just to get some agreement among FTAC members that, yeah, these ideas should belong in any healthcare system. Yeah, these ideas over here are perhaps transitional, and then maybe transitional only. Maybe they wouldn't work in the eventual system in the long run. But so either or, they leave them in the toolbox, or they're just a transitional solution. And so we've tried to capture sort of the range of where FTAC members might place these or organize these. And so once we sort of had some agreement on the structure of how to recommend these, then we can really dive into, okay, what does a recommendation on global budgeting look like, for example? And FTAC really, like you mentioned, the resources, you don't have the resources to necessarily study what this would exactly look like in the state system. But the recommendations from FTAC and then to the commission could be, the Office of Insurance Commissioner has done a study on hospital global budgeting and the savings for that. So what further does the state need to do to study or come to some decision on that specific topic, for example? And so our goal is, once we have this basic understanding with FTAC members, we really start diving in on those specifics and prioritizing what specifically FTAC would like to recommend. And I will move on to David's comment.
Yeah, thanks, Todd. I'll say this just so the rest of you can disagree if you think about it differently. I don't think about it so much in these code terms as I do what practices are in place today and should those continue or stop, versus what are new practices that we're recommending the commission take a stand on. So for example, utilization management happens today in the current system. And would we be recommending that utilization management stop? Fraud, waste, and abuse detection, that happens extensively today. Are we recommending that stop? Hospital global budgets don't happen today. Reference-based pricing, it happens on a limited basis, not yet in our state. So I think it would make more sense to me if we were to organize into those existing versus new buckets.
That makes sense, David. Thank you. Go ahead, Mary.
I was going to jump in. David, would it make sense also if we said, okay, here's this thing we're not doing, but we think we should start? Also asking the question, does this fit transitional, universal design, or potentially both?
Yes,
so
I do think that's
have there be a part B to your question. Okay.
Yes.
I think one consideration here also is that under these examples, we've kind of provided them as examples and not exactly with any recommendations on how they fit into a newer or interim transitional sort of solution. So that would be also a next step for healthcare authority staff to work with you all to sort of flesh out the key considerations under some of these examples that you prioritize. So not just providing an example to the commission of it, but providing what FTAC imagines needs to be considered to modify or implement or get rid of and replace with something else. So there are key considerations that I think do need to be developed under each of these recommendations or ideas that you all work with. But we will continue to work on organizing them in a way that makes sense along those lines. And I'll move to Pam.
Yeah, I have, when I looked at the list, that I realized that I thought that some of them were actually at cross purposes or redundant. You wouldn't, if you did one, you wouldn't need the other. Some of this is because the commission hasn't really told us what kind of system they want. So when we talk about universal system design, we talk about it in kind of an agnostic way. We're not talking about whether the carriers doing the cost management, or is some government function doing that for the whole system. That makes a huge difference in how you manage these things. And I like all the things in category 2 quite a bit. We do all those things, then we don't need to do some of the other things at all. So maybe the way that David's framed it, let's start this, let's stop that, do more of this and less of that. We could do it that way, but it would be, at what point does the commission start to develop some preferences for where we're headed? Or do we continue just to do things this way? I don't know if I'm making sense, but that was my sense when I read it. And I can certainly give that in my feedback, kind of, how I would weight it and why. But that also depends on a particular approach to the system.
Thank you, Pam, for that feedback. We will continue to work on how we organize these and present any suggestions that you all have among them to the commission. Roger?
Yeah, I thought Pam raised a really good point. And if I might just give a concrete example, because it's one in here that talks about competitive selective contracting, which our state has done. Pam is aware of that with the work that was done for the Healthcare Authority for Cascade Select. That has application, back to Pam's point, if in the new system there are going to be health carriers. If there's not, then this notion of competitive contracting really doesn't have a place. I mean, there's other things you do. So my only point being, I'm just kind of reiterating that it's kind of hard in some of these because we don't have kind of a more general structure, as Pam is indicating, upon which to place some of these, because some of them just wouldn't be relevant. Again, if we're not going to use health plans, for example.
Yeah, and I'm just sort of, any guidance from you in terms of how we rank these, and maybe I think the way David suggested is workable. So.
Yeah, if I could jump in, keeping an eye on the clock. So I want to make sure that we are capturing correctly what is coming out of this section of our meeting. Staff will work on the principles. Kai may send us one about measurement. We will condense them. We will send them around via email, gain consensus, and then it goes in April to the commission as a recommendation from FTAC, and then the commission can, accept or reject that set of principles. And then the general grouping, categories 1 through 4, make sense to people. We're going to stick with those categories in the way that we organize things. But on this list down here, we're going to slightly change the question, looking at things that are in place, not in place. So, do we not want to keep this? If it's not in place, do we want to add it? And then part B of that question is, should this be universal design? Should this be interim solution? Potentially both. And we come up with a different way of gathering that feedback from the FTAC members. Does that sound right to everybody?
Yes. Thumbs up.
Yes,
Okay.
Mary, I'd add one thing. I think Roger's point about governance dependent
thank you.
tactics is an important attribute if we can include that.
Okay. And Todd, I just completely jumped in and I don't remember if you had another section, and Kai, I see your hand is up.
Just a very quick thing. This is very helpful categorization. And I wonder if in the next iteration, you could add an additional sentence to each of those that don't have it, a sentence on the size of the opportunity, any evidence around that. Some of them have it, but the other ones don't. And so that would help us also to consider prioritization. Yeah.
Thank you.
I would just finish with one more thing on this. If there are ideas in here that you as an FTAC member think need to be prioritized in the transitional solution, I think that would be really helpful from where we are now to moving to a unified system, and some key considerations about the transitional solutions. I do agree that there's a lot to be determined on the design, and so there may be choices to be made there. But if you see opportunities that are highlighted here, or you have others on transitional solutions, I think we'll request that from you all as well. Roger?
So can I follow up to your point there, Todd? A good point. As we're doing this, I guess I would like to, what's what I'm looking at, emphasize to the commission, especially in this area of transitional solutions, that by us recommending them, let's say FTAC, and having this exchange, that the commission is prepared to embrace that these things can't happen in a vacuum, and the commission to some degree needs to assume some responsibility for, in a proactive context of engaging with the legislature and the governor on various ones of these solutions. Otherwise, they're into report, isn't that nice, and there they stay. And I'm particularly emphasizing that in the area if we think there are opportunities in this transitional period.
I think that's
Thank
a good
you.
point, Roger. Yeah.
I will hand it back over to David. I think we need to wrap up for the day, so I appreciate all of your ongoing participation. Thank you so much.
Well, thanks a lot, Todd. That was a great session. Thank you, everybody, for a lively and productive meeting today. If you felt like Mary and I could run things better so you have more chance to say something you didn't get to say, please send me that feedback and we can take that into account. Normally, I would say we'll share this discussion with UHCC, but as you know, we've talked about some follow-up email that we're going to do together as a committee. So I'm going to debrief with Mary and Todd tomorrow, and then you'll receive some communication about how we're going to handle it. So before I sign us out, Bob, you have a question?
Well, I think you answered the question. I was just wondering what the follow-up would be on these coding of these different, but it sounds like you're going to come back to us with instructions about what to do.
Exactly.
Yeah, okay, good. That's fine. That's what I needed. Thanks.
Okay, good. Our next meeting as a committee, our next Zoom meeting is going to be Thursday, May 13th at 2 p.m. And it's now 4:31, and this meeting is adjourned.
Thank you, everyone.